So the next video, we're going to be discussing intracranial pressures. So as you guys know, intracranial pressure is influenced by three essential components: the brain tissue, the blood, and the cerebral spinal fluid, or your CSF. And of course, you need a balance among these components to maintain intracranial pressure. So there's multiple factors that influence ICP. It may increase or decrease it. A few would be arterial pressure, venous pressure, posture, temperature, blood gases, as well as the CO2 level. So with the regulation and maintenance, you have what is known as your Monro-Kelly doctrine. So if one component increases, another must decrease to maintain intracranial pressure. So the normal value of ICP is 5 to 15 millimeters of mercury. So it's elevated if greater than 20 millimeters of mercury and it is sustained. So ICP, it can be measured in the ventricles, the subarachnoid space, the subdural space, the epidural space, or the brain tissue using a pressure transducer. So with regulation and maintenance, you have normal compensatory adaptations. So changes in the cerebral spinal fluid volume altered by absorption or production and displacement in the subarachnoid space, changes in intracranial blood volume via changes of vasoconstriction or vasodilation, changes in tissue brain volume by distension or compression, and ability to compensate is limited. So if the volume increase continues, ICP rises, and you have decompensation. So with cerebral blood flow, I'm not going to read the definition, you guys have that there. So the maintenance of blood flow to the brain is critical because the brain requires a constant supply of oxygen and glucose. The brain uses about 20% of the body's oxygen and 25% of its glucose. So cerebral blood flow, you see autoregulation there. It's only effective if the mean arterial pressure is 70 to 150 millimeters of mercury. So when this pressure is exceeded, the vessels are maximally constricted, and further vasoconstrictor response is lost. So if you recall, the mean arterial pressure, it calculates overall blood flow and thus delivery of nutrients to the various organs. It's a good indicator of perfusion to the organs. So if you recall, the mean arterial pressure, that equals 2 times the diastolic blood pressure divided by 3 plus your systolic blood pressure. So with cerebral blood flow, you have cerebral perfusion pressure, CPP, and CPP, that's equal to the mean arterial pressure minus the intracranial pressure. And the normal level is between 60 to 100 millimeters of mercury. Less than 50 millimeters is associated with ischemia and neuronal death. So effects of cerebral vascular resistance. So as you see, the CPP equals flow times your resistance. So cerebral vascular resistance, that's generated by the arterioles within the cranium, links the CPP and the blood flow. When the cerebral vascular resistance is high, blood flow to the brain tissue is impaired. Transcranial Doppler is a non-invasive technique, and that's used in the ICUs to monitor changes in cerebral vascular resistance. So with pressure changes, compliance is the expandability of the brain. It impacts the effect of volume change or pressure. Compliance equals volume divided by the pressure. So with low compliance, small changes in volume result in greater increases in pressure. So there are stages of increased ICP. Stage 1, this is total compensation. Stage 2, you have a decrease in compensation. So there is a risk for increased intracranial pressure that's secondary to an injury. With stage 3, you have failing compensation, clinical manifestation of increased ICP. So you see Cushing's triad. So with that, you have irregular decreased respirations, and that's caused by impaired brainstem function, bradycardia, systolic hypertension, which you see that with widening pulse pressure. In stage 4, herniation is imminent, and of course death occurs. So with the cerebral blood flow, factors affecting cerebral blood vessel tone, with carbon dioxide, an increase in carbon dioxide relaxes smooth muscle, it dilates cerebral vessels, it decreases cerebral vascular resistance, and it increases cerebral blood flow. With oxygen, lactic acid can accumulate, and that causes tissue hypoxia. Hydrogen ion concentration, you would have acidosis. With increased ICP, that of course is life-threatening. So with an increase, it could be caused by trauma, hemorrhage, growth, or tumors, as well as hydrocephalus, edema, or inflammation. Increased ICP, it can impede circulation to the brain. It can impede the absorption of CSF. It affects the functioning of the nerve cells, and it leads to brainstem compression and death. So of course, any increase in any of the 3 components, as you see there, leads to increased cerebral edema. So when we talk about herniation, and if you're looking at your PowerPoint, you see A there. So A, that is normal. B, in that brain, you see a shift of intracranial structures. So you have compression of the brainstem, your cranial nerves. Herniation forces the cerebellum and the brainstem downward. If compression of the brainstem is not corrected, then the patient can have respiratory arrest, and that occurs due to compression of the medulla. So with cerebral edema, you have an increase in extravascular fluid in the brain, and there's a variety of causes. The 3 types would be vasogenic, cytotoxic, and the third is interstitial. So with vasogenic cerebral edema, this is the most common type, occurs mainly in the white matter. It can be due to a fluid leak from the intravascular to the extravascular space. There's a variety of causes. It could be due to a brain tumor, an abscess, ingested toxins, and that can cause an increase in permeability of the blood-brain barrier, and it produces an increase in the extracellular fluid volume. So the speed and extent of the spread of the edema fluid are influenced by systemic blood pressure, site of the brain injury, as well as the extent of the blood-brain barrier. And obviously, if this concludes, coma and death ensue. With a cytotoxic cerebral edema, you have a disruption of the cell membrane integrity. So, secondary to destructive lesions or trauma to the brain tissue, this results in cerebral hypoxia or anoxia and in syndrome of inappropriate ADH secretion. So, in this type of edema, the blood-brain barrier remains intact. Cerebral edema occurs as a result of fluid and protein shift from the extracellular space directly into the cells, with subsequent swelling and loss of cellular function. With interstitial cerebral edema, this usually results from hydrocephalus, which is the buildup of fluid in the brain, and it's manifested by ventricular enlargement. This typically, as you know, it's treated with a ventriculostomy or a shunt. So some clinical manifestations. Obviously, a change in the level of consciousness. So you definitely need to know that level of consciousness, this is the most sensitive and reliable indicator of the patient's neurologic status. So changes in LOC are a result from impaired cerebral blood flow, and that causes oxygen deprivation to the cells of the cerebral cortex. So with a change in vital signs, with Cushing's triad, that may be present, but often do not appear until ICP has increased for some time or is suddenly markedly increased, such as head trauma. So ocular signs, this can be due to compression of cranial nerve 3, the oculomotor nerve. It results in dilation of the pupil on the same side or the ipsilateral to the mass lesion. Sluggish or no response to light, inability to move the eye upward, as well as ptosis, which is spelled Ptosis, of your eyelid. That's when the eyelid droops. So with clinical manifestations, with the change in level of consciousness, again, that is resulting from impaired cerebral blood flow, which causes O2 deprivation to the cells of the cerebral cortex. So you may see a flattening of the affect, so a change in orientation, or a decrease in the LOC, which leads to coma. We mentioned Cushing's triad, the widening of the pulse pressure, bradycardia, irregular respirations, as well as a change in the body temp. And that can also occur because of the increased intracranial pressure affects the hypothalamus. So compression of the oculomotor nerve, which is cranial nerve 3, you see the unilateral pupil dilation, sluggish or no response to light, inability to move the eye upward, or eyelid ptosis, which is drooping or falling of the upper eyelid. If you recall back to 320, you see ptosis in cluster headaches, which, if you remember, cluster headache, that's more common in men, typically treated with 100% oxygen. 6 to 7 liters of oxygen is applied by face mask, if you remember that. So other cranial nerves, diplopia. double vision, blurred vision. There's changes in extraoculomotor changes. So with oculomotor nerve, that's cranial nerve 3, oculomotor. That's the majority of all extraocular eye movements. Now, cranial nerve 4, which is the trochlear nerve, you see the superior oblique changes there, the abducens, which is cranial nerve 6. You see changes in the lateral rectus. And of course, that's when you move your finger to different sides of the eyes, is how you do that testing. So you can also see a decrease in motor function. So hemiparesis pelagia. So hemiparesis, that's characterized by weakness on one side of the body. A person with hemiparesis might not be able to move their arm or may feel tingling or other odd sensations on just one side. With hemiplegia, that's paralysis on one side of the body. Those stereotypes of paralysis suggest that paralysis completely removes the ability to move. The reality is a bit more complicated. People with paralysis may retain some sensation and degree to which they're paralyzed, and that can change over time. Another thing that we're going to discuss in this is decebrate posturing as well as decorticate. With decebrate, as you see, that's extensor. That indicates more serious damage. I do want you to look at some pictures of those two types of posturing, but you should also know them in written form as well. Due to putting the test on Blackboard, I couldn't post my pictures, so I went ahead and I did the written form on the quiz. So if you're looking at the next slide on the PowerPoint, if you're looking at A, that is the decorticate response. So you have flexion of the wrist as well as the fingers, with adduction in the upper extremities. And remember, with adduction, you're pulling your arms closer to the body. Then you have extension, internal rotation, and plantar flexion in the lower extremities. With B, decebrate response, all 4 extremities are in rigid extension with hyperpronation of the forearms and plantar flexion of the feet. So make sure that you definitely know those two. C is a decorticate response on the right side of the body and decebrate response on the left side of the body. You won't see that on the quiz. D, this is ophthalmotonic posturing. So this is decebrate posturing where the neck and the back are arched posteriorly. You won't be responsible for knowing that on the quiz the following Friday. So some clinical manifestations: headache, compression of the intracranial structures. It's often continuous. It's worse in the morning. People may complain of straining, agitation, or movement may accentuate the pain of this headache. With vomiting, it's usually not preceded by nausea. It's often a non-specific sign of increased intracranial pressure related to pressure changes in the cranium. And the vomiting can be projectile as well. So some complications, major complications of uncontrolled ICP are inadequate cerebral perfusion and cerebral herniation as well. So with cerebral herniation, you have tentorial herniation. And this occurs when a mass, a lesion in the cerebrum, it forces the brain to herniate downward through the opening created by the brainstem. An uncal herniation, that occurs with lateral and downward herniation. Cingulate herniation, that is the most common type, and it occurs with lateral displacement of brain tissue beneath the falx cerebri. And if you go to the next slide, there is a photo, and I would encourage you to make sure that you're looking at your book, look at your PowerPoints, to better help you understand the different types of herniation. So when we talk about diagnostic studies, obviously a CT scan, an MRI, these are used to differentiate many conditions that can cause increased ICP to assess the effect of the treatment. So with a PET scan, that can diagnose ICP. Moving down to lumbar puncture, you don't want to do a lumbar puncture if there is cerebral herniation. That could occur from the sudden release of the pressure in the skull from the area above the lumbar puncture. So with measurement of ICP, there are guides to clinical care. Some of you might have done this during your rotation. If you're working in an ICU, the Glasgow Coma Scale, less than or equal to 8. So this scale, it's a method assessing a client's neurological condition. The scoring system is based on a scale of 1 to 15 points. 15 is fully awake. Abnormal CT scans or MRI, you're looking at hematoma, contusion, as well as edema. So the Glasgow Coma Scale, and when you turn the next slide where it says table 38.2, or in your book, I want you to have the Glasgow Coma Scale in front of you because there's a question that you do have to answer. So you do need to have this in front of you. So this talks about the eye-opening response, and you see here where it gives spontaneous, that's a score of 4, where no response would be a score of 1. Best verbal response, as you see, 5 to a score of no response of 1. Best motor response, obeys commands, to a 6 down to no motor response, which is 1. So the best response, as you see, is 15. A comatose client, 8 or less. So again, have that out during the quiz so you can look at that. I don't expect you to memorize that. So turning to the next slide, you see potential placement of ICP, monitoring devices. So as you can see, this can be done in various parts of the brain. It could be in the subarachnoid space, the epidural to the subdural space. So measurements of ICP. So a ventriculostomy, this is like the gold standard of looking at the patient's ICP. So a catheter is inserted into the lateral ventricle. It's coupled with an external transducer. So this technique, it directly measures the pressure within the ventricles. It facilitates removal or sampling of cerebrospinal fluid and allows for intraventricular drug administration. So if you look at the next slide, you see where the ventriculostomy is in place, and the cerebrospinal fluid can be drained via a ventriculostomy. When ICP exceeds the upper pressure or parameter limit set, intermittent drainage, this involves opening the 3-way stopcock to allow CSF to flow into the drainage bag for brief periods until the pressure is below the upper pressure parameters. So one thing that you have to remember too, with this does require a leveling system. So in the system, you've got the transducer, that's external. It's important to make sure that the transducer of the ventriculostomy is level to the intraventricular foramen. So a reference point for this foramen is the tragus of the ear. So when the patient is repositioned, the system needs to be re-zeroed. So the one thing that you want to do, and this is major, is you want to prevent and you want to monitor for infection. With ICP monitoring, more than